Absolutely.
Welcome back. And welcome back to our folks with us virtually from all over the globe.
All over the globe. So how many of you were able to go to a Birds of a Feather session just recently? Okay, perfect. And by applause, how was it for you? All right, great.
Good stuff.
So, should I tell my story?
Yeah.
Okay, so I have a really funny story to tell you guys. So, it's Vegas, right? So, what happens in Vegas stays in Vegas. However, there are some funny things that go on in Vegas. So, my husband and I went out last night, and we were going to grab a slice of pizza. So, we went into one of the pizza shops on the Strip. We're in the shop. All of a sudden, we look out, and my husband says to me, "Is that person sitting in my scooter?" And we have a picture of this woman sitting in his scooter. She just made herself comfortable in there. It was kind of like Goldilocks. This one fit her just fine, and she was happy about that. So we went up to her and we said, "I think that you're sitting in our scooter."
Yeah.
And she was very pleasant, and she got up with a big smile, and she said, "I was just keeping it warm for you." So I just want to let you guys know that this does happen. So you might want to pay attention to those scooters as you leave them throughout the town.
Excellent, excellent stuff. All right, let's get started for our afternoon sessions. It just really does give me a great honor to introduce our next speaker. For those of you who have spent any time on our Ask the Expert session, you're in for a real treat here for this next half hour. I've got to do this right for Dr. Perlman, so I hope you don't mind if I read this. Susan Perlman is currently a clinical professor of neurology and the director of the Ataxia Center at UCLA Medical Center in Los Angeles. She's been the head of the Ataxia Center at UCLA since 1983. She's worked in ataxia diagnosis for over 30 years and has networked with other ataxologists across the country and around the world, trying to build a better collaboration in the development of treatments and ultimately cures. Please welcome Dr. Susan Perlman.
Always good to see you. Thank you. All right.
Good to see you.
All right, so I just have to make sure I can deal with the technology here. So how do I advance the slides? That's the question. I presume it's the green arrow that's pointing right?
Yes, green arrow.
Yay, okay. So there's the disclaimer. Here's my own, and it's going to be hard to see that. I will probably cheat and try to see there. This is, groups that I've been involved with. And in my Birds of a Feather this morning, we talked about what we were hoping, what we were most excited about for this conference. And I was excited to see patients and families that, I take care of or that I haven't seen since the last conference, to meet with my colleagues that I see in two dimensions, but, to actually get together in person, but also meet to people in industry who can give me updates on where their programs are going and how we can enhance their ability to bring drugs, through the pipeline, into use in the ataxias. So I work with a number of drug companies. I'm not married to any of them, and I think they all are doing very good work. So things you don't want to hear from your doctor. You have ataxia, there's nothing I can do. I don't know what you have, and there's nothing I can do. And in our Birds of a Feather this morning, people were, distressed by some of the, comments they had received from doctors who, really didn't understand ataxia. So you need to play an active role in educating your doctors and keeping communication open. Don't be afraid to bring up things that you've seen on various websites or heard from other patients and practitioners. And be sure that your doctors know what you are doing outside of what they have prescribed. I was working with a patient with a drug that, we had to monitor his liver tests because, we knew it was metabolized by the liver, as so many drugs are. And all of a sudden he came in and his liver tests were off the chart, and I couldn't figure out what had happened, And it turned out the month before he had started a Chinese herbal program as a cleansing program. And it happened that those herbs, were a bit hard on the liver. So, he stopped the herbs and his liver went back to normal. So it's important that your doctor know what you are doing outside of what is in your actual record. So things your doctor can and should do. Obviously, make sure that you have ataxia. Confirm that there's a genetic or non-genetic basis to it. Clarify any risks for family members. I think one of the hardest questions to deal with from my side is, you have somebody who clearly it's an ataxia, clearly there are other family members involved, but you don't know what the genetic factor is. And they have questions about the next generation. What can I tell my kids? Can they be tested? But if you yourself don't have a confirmatory gene test, there's no really way to test your kids to confirm anything. Make sure that your doctor looks not just at your balance, but at disability needs, support services that you might benefit from, and also your psychosocial status. It's frustrating to have a disorder that is progressive and has no cure. I'm currently seeing the third generation of some families with identified genetic problems. We've had the gene test, we know what's in the family, and there's still nothing I can do to slow that progression. So I think that's an important discussion to have with your doctor. Are you discouraged? Are you frustrated? Is there something the medical community can do to relieve that frustration? Are you thinking about suicide or assisted suicide? I mean, these are things that you don't just want to keep to yourself and keep from your family. It's important that your doctor helps you track down clinical research that you can participate in, and drug trials, obviously, when they become available. Rehab always helps, but you want to work with a physical therapist who understands neurologic problems, not just orthopedic problems. Symptomatic medicines can improve quality of life, especially if pain is an issue. There are disease-modifying treatments in the pipeline, and most ataxia specialists are willing to consult with your own doctors. If you have a good doctor, you're working well, but you have questions that they just can't answer, I've gotten calls from outside physicians, outside neurologists, then I'm more than willing to talk with them, and you should, make sure that avenue stays open for your own doctors. So this is, kind of small. There are 2 publications that talk about treatable ataxias, and I think you'll have access to these slides so that, you can go back and find these articles, looking at things that might be from the immune system, might be poisons or toxins, might be infectious causes. Even in a family where there appears to be a genetic disorder, you're not immune from other problems. And if all of a sudden your ataxia seems to be going downhill more rapidly than you would have expected, make sure that there's not some other process going on that could be affecting the cerebellum. And then this particular one, focused on gluten ataxia, which, people are talking about, vitamin E deficiency and other vitamin-related issues, as well as some inborn errors of metabolism, where you can sometimes make an input with changing diet or dealing with a medication that will impact your metabolism. So there's a neurology meeting coming up next month in San Diego, and this is the annual American Academy of Neurology. It's a huge meeting. And people can submit their research. They have abstracts, they'll have poster sessions, they'll have presentations in groups. And so I went through all the abstracts for the meeting coming up. And these are the topics that seem to be, dealing with ataxia. So there were, a few things about, the newly discovered genetic ataxias, ataxia 27B and canvas. There were, a number of things looking at other spinocerebellar ataxias, other genetic and acquired ataxias, autoimmune ataxias, a number of presentations, multiple system atrophy, there were 2, and then 15 others that had something to do with ataxia. So I think in prior years, the ataxia exposure at this very well-attended, very large neurology meeting wasn't so great. So I think now we're gaining a little foothold, with the clinical research community and treating physicians who attend this meeting. So there are 2 FDA-approved therapies for 2 of the common genetic ataxias. One is Skyclarys for Friedreich's ataxia, and the other is a new drug, just came out, Aquanersa, for Niemann-Pick type C, which is an inborn error of metabolism that can affect children but can also affect adults. Both of them can be identified with genetic testing. So, if you're, pursuing a diagnosis, hopefully the testing that is ordered for you is going to cover these areas if it's appropriate. There are no other FDA-approved drugs for the treatment of any other type of inherited ataxia, but there are 2 that are in the lap of the FDA right now. One is troriluzole for spinocerebellar ataxia, and the other is vatiquinone for Friedreich's ataxia. And hopefully we'll hear some good news over the next few months about those. And troriluzole is currently in an expanded access program for any type of SCA. So if you have a genetic diagnosis of SCA 1 through 50, you could qualify to obtain troriluzole through this expanded access program. So the road to FDA approval. This is what companies, drug development companies, biotech and pharma have to go through to make sure that they can cross that finish line. They have to have a good drug that works in the lab, works in animals, and is safe. They have to have enough money, usually through big pharma, to take on human trials. Established rating scales, and you've probably heard about the SARA, the FARS, the ICARS, and the MICARS, which are in common use now for research, but also for clinical measures. And some of you, you'll go in to see your doctor and you'll say, well, what's my SARA score today? I do SARA on every ataxia patient of any cause that I see, because I know my exam translates to a number that, is meaningful for my, disease management. But when I have that patient see one of my trainees, they may generate a totally different SARA score. So it's very much dependent on the examiner's skill and ability to follow through. To design a trial, you have to decide who's going to take part, what they have to have, what's going to exclude them from the trial. How many patients can enroll? Some studies enroll, 20 patients altogether, and with hundreds of patients who might want to become involved. And how long are they going to run the trial? If there's a placebo, do you want to sign on for a trial that's going to keep you on a fake medicine for 2 years? So these are things that the companies working on designing these trials and working with the patient community, recruiting people to participate in the trials, they have to explain this and find out, how people will respond to being on a placebo for a year and a half or 2 years. So this is the pipeline that we've probably seen on the Cure FA website for Friedreich's ataxia. You see there's a lot of lines that are moving over towards the right-hand side, which is where the FDA approval comes in. But there's a fair number of drugs, candidates that are still on the left-hand side, where they're still working out proper dosing. They're still trying to understand side effects and risks before they can actually move into a study that would lead to FDA approval. And it is a slow process. From the first light bulb going off, the first drug in the lab that looks promising, it can be 15 years to get it across the FDA finish line. Skyclarys did make it across the finish line, and this is just stuff I took right from the website about dosing and things to monitor. Biogen, which now holds this drug from Reata, who did all that original research and got it approved, is planning to do a study in children. Right now, it's available only for age 16 and over. But they feel that the earlier you start such a drug, symptomatic benefit definitely, but potentially it will be disease modifying. We've seen slowing of progression in the adults, and with the children, potentially information we have from the natural history study that they could be in wheelchairs within 10 years. Maybe a drug like this, which is not a cure, could stretch that to 20 years. They could be on their feet. maybe with some assistance, but not confined to a wheelchair. So I'm glad to see that Biogen is going to be moving this forward, and potentially the mechanism of action of this drug on the mitochondria, which is a target organelle in Friedreich's, could be applied to other ataxias where the mitochondria become innocent bystanders. So Huntington's disease and some of the spinocerebellar ataxias in the future, we might be able to run studies that could, identify some benefit for these other disorders as well. So this is the prescribing information, and I think the one thing that most prescribers are going to be careful of is following liver function and potential side effects, most of which go away after the first month, but you want to be sure that you closely monitor people on a drug that could affect your liver, at least for 3 months to make sure that you're not doing something that could be damaging, and that's for Skyclarys and for many other drugs as well. This was the results of the first arm of the trial data that the FDA was impressed with. It shows the blue line, which was treatment patients at the end of the first year. The gray line is the placebo patients. The first 3 months, everybody got better. That's the placebo effect. But by the end of the first year, the benefit in the treatment group, it was like turning the clock back 2 years on the natural history course that was expected. And then when they took it further out to 3 and 4 years, this slow worsening kind of crept in, but it was still at half the rate. So I think this study in Friedreich's is going to be a model for the troriluzole data that's being looked at by the FDA and for other trials. Can you show symptomatic benefit early on, and can you show slowing of progression that matches what Biohaven is hoping to show compared to Skyclarys and other companies as well. So I think the work that in the MOXIe trial for Skyclarys is setting a good foundation for future drug trials. These are the pipelines that are on the National Ataxia Foundation website. This is for SCA1, and it's kind of a small pipeline. That blue line is troriluzole. The orange lines are things that are going to block the production of the bad protein. Then for SCA2, we also have a pipeline like that. For SCA3, there's a few more candidates in there, and I think SCA3 draws more attention from biotech and pharma because it is the most common of the dominantly inherited spinocerebellar ataxias in North America and in Europe. All those red lines are potential gene blockers, I refer to them, where they block the production of the abnormal protein and then can protect nerves from nerve degeneration. And again, that blue line on the top is the troriluzole line. And then for other rarer ataxias, ataxia type 6, type 7, type 8, type 10, 17, and DERPLA, one company that I was interested in that appeared in pretty much all those pipelines. You think disease-modifying therapies are going to be very specific. What works in Huntington's, won't work in Machado-Joseph's. But Enzerna, with their technology, which I don't fully understand, appeared on most of those pipelines. So they think they have an agent that might work across all triplet repeat disorders of that type. So that's one that I'm going to keep an eye on. On the NAF website, they have links to the pipelines for ataxia-telangiectasia and also for multiple system atrophy. And this is a chart that I put together for active trials for disease-modifying therapies for multiple system atrophy, just so that we can get a sense how many active trials there's going to be for MSA. We've had several failed trials, rifampicin, the Open Biohaven that, I was involved in, and the verdiperstat trial. But there are several companies now that are going to have active trials in the coming year that people with MSA should take note of. There is one approved drug in Japan for ataxia, which many of you know about, talturelin. It is an analog of a natural hormone that occurs in our brain. that seems to work better than our natural hormone alone. It has neuroprotective effects and other effects and seems to help symptoms of ataxia. And we've known about it for many years. It's licensed in Japan. You can obtain it from a licensed physician in Japan, and it's kind of hard to get it if you don't go to Japan. Although one patient assured me they were able to get it online. I'm not sure how they did that. And I've currently got 2 or 3 patients who are still taking this. They have relatives in Japan that they visit regularly and can pick up a supply, and they feel it is helping. So my small, group of patients that I have some experience with, an interesting drug that has never made it to the FDA for consideration of approval outside of Japan. 2 drugs recognized by the American Academy of Neurology for off-label use for ataxia. They're not approved, but they're in common use. One is 4-aminopyridine or dalfampridine, Ampera. It was noted in the literature, that was summarized in that American Academy of Neurology publication to be helpful for episodic ataxia, for which acetazolamide is also used. It has been around for a long time from compounding pharmacists, and it's been used in spinal cord injury. It's been used in ataxia for years now. And it was approved for multiple sclerosis on the basis of being able to improve walking. It's quite expensive, even as a generic, and even with a compounded formulation, it could cost a little over $100 per month to get a month's worth. And the benefit of using a compounding pharmacist is you can use a lower dose as opposed to jumping into the full dose of 10 milligrams. But through a coupon service, GoodRx, you can get it as low as $50 per month. And, one of my colleagues a year or so ago, turned me on to the Mark Cuban, program that you can sign up for, which you can get it even cheaper. So, I think this is one of the drugs that when I have a patient with progressive balance problems, I will discuss this with them as something that might help their balance. And the same with regular riluzole, approved for Lou Gehrig's disease, but available as a generic. Again, you can get it fairly cheaply through coupon services. It has some restrictions. You have to take it again every 12 hours on an empty stomach. It can affect your liver, as so many of these drugs do. But there are some publications from Europe that it can be helpful symptomatically for ataxia and in slowing progression of ataxia. And even though a recent study in spinocerebellar ataxia type 2 didn't show benefit, I still offer this as something to try to improve symptoms of ataxia. So I have dalfampridine, 4-aminopyridine, I have riluzole. And then there's an older drug that you can use symptomatically, amantadine, which may help balance, may help tremor. It can be constipating. But again, manageable symptoms, side effects that could interfere with the benefits of these drugs. So, and this is a long-term follow-up that Dr. Zesowitz and her colleagues put together for SCA7 on regular riluzole, suggesting that it could help vision. So I think, there are certainly repurposing of available drugs, which, the ataxia clinicians are still looking into. I did a little study of troriluzole on my own. It's a prodrug. It turns into riluzole. And, hopefully the FDA will be able to approve this. The expanded access is available. And this was, one of the publications, from Biohaven. But, I did my own little study in people with various other ataxias, genetic and non-genetic. And the only group that didn't have some response to troriluzole was MSA. For some reason, they just didn't respond. And a few people who had dizziness couldn't tolerate the side effect of dizziness. But overall, I think 4-aminopyridine, dalfampridine, riluzole, and hopefully troriluzole in the future are going to be things that you can ask your doctor about and try to help balance and coordination. If your ataxia includes spasticity, includes a peripheral neuropathy, speech and swallowing problems, tremor, dizziness, there are other approaches. And here's, again, another really good article summarizing all those other non-ataxia symptoms that ataxia patients can experience and what drugs are available to control them. National Ataxia Foundation has a fact sheet, for any symptoms that you have that aren't just simple balance problems, drugs that are available that can be used, and it goes on there and on. And then I had my own little checklist that I used for patients, where if you read the fine print on any of these drugs, side effects of ataxia, dizziness, and tiredness may not be the best thing for somebody with ataxia, but they may be worth a try if, certainly if you have, a bad antibody, an autoimmune cause of your ataxia, the immune treatments do seem to have some benefit. Antioxidants, there are several out there. There's a whole lot more that probably don't do as much, but these are reasonable ones to try in supplements. There are a number of drugs used for symptomatic benefits for ataxia. We talked about amantadine, riluzole, and dalfampridine. For tremor, our movement disorders colleagues have a large number of drugs that can be used for tremor. And for dizziness, that's the challenging one. There's twice as many drugs that have publications about, we tried this for dizziness, I tried that for dizziness. My colleagues at Johns Hopkins favor memantine. I've tried it for dizziness. I don't think it that helpful. There's a group of people that are, very interested in citalopram, Celexa, for Machado-Joseph's disease, spinocerebellar ataxia type 3. There's a lot of mouse studies which suggest it can be helpful, but really no human trials yet. And it's an antidepressant drug that's in wide use. If it did have a benefit for SCA3, it would be important to demonstrate that with clinical trials so that we can then, embark on using it with confidence. Fatigue is common in cerebellar ataxia, possibly on a central basis, but it could just be muscle fatigue. A lot of things can lie behind fatigue, which can be very limiting, will force you to pace your activities, or limit or eliminate some activities. I think two of the more important areas are a sleep disorder. If your sleep is not restorative, you will be fatigued the next day. And the other is other medical problems that can contribute to fatigue independent of your ataxia. So it's important to follow up with your general medical people to make sure your sleep is good, to make sure you're not overdoing, and to know what your limitations are so you can continue to be functional in areas that are important to you without paying for it, with having to go to bed for 2 days to deal with the fatigue. Trials that are not moving forward at present in the U.S. One of the MSA drugs from Biohaven is still in an open label extension, but is probably not going to move through the FDA for approval. Venglustat for late onset Tay-Sachs had some positive results, but didn't have enough improvement in the patient exam and performance to warrant moving forward, although they haven't totally given up on it. Selos, intravenous trehalose treatment to break up the bad protein that might build up in the SCAs, especially SCA3, had some favorable prior data. They ran out of money and have stopped the study for now, but I don't think it's totally gone. The stem cell group from Taiwan, Steminent, has a very promising study for SCA3, potentially SCA2 and SCA6, and hopefully it will come to the US. And there are antisense groups, with gene blockers that hopefully will also come to the US, hopefully later this year. So these are the things to track over the upcoming months. There's quite a few things, and these vendors all have tables out in the reception area, so you might want to stop and talk to them. Diet for Ataxia did this book 25 years ago, The Ataxia Diet, which is basically a common sense approach to diet. And it's in the book, and I don't have to go into that. But there is no dietary cure for regular ataxia. There are some inborn errors which can be altered with supplements, and you need genetic confirmation before you do that. There's, the ataxias that are genetic seem to emerge in most of us, when aging is kicking in. So you've had the gene since you were born. Why no symptoms until you're in your 30s or 40s? And that's when the brain begins to age. So are there pathways of aging that trigger, or take away reserve so that your ataxia gene begins to gain strength, as it were? And there are definitely approaches to aging. I wish we had a cure for aging, but, anti-aging diets, there's a ton of them out there. The risks of trying a popular diet, you want to be careful and discuss it with your physician before you embark on it. Weight loss medications, we could have a whole session on this. They do have potential side effects. They have to be used carefully. They're very popular now, especially in Hollywood. Gluten-free diet, it's worth trying. It's a hard diet to keep with. The anti-inflammatory diet, worth trying if you want to do it for 3 months. Intermittent fasting, not so clear that it helps. There are definitely things that can enhance energy production, the mitochondrial diet, the ketogenic diet, but these are hard to continue over long periods of time. Should you take vitamins? Only if you tell your doc, what you're doing. Weight loss in chronic disease, if you're losing weight and you can't figure out why, you need to discuss that. Websites, for all this information, and my team at UCLA that works with me. So thank you very much. A lot of stuff to cover, and definitely room for discussion.
Thank you, Dr.